Hello everyone, I'm David. I'm the Marketing Manager at Intouch with Health. Thank you for joining us today. We really do appreciate it, and welcome to the latest Intouch with Health webinar. Today, we're focusing on implementing a digital pre-operative assessment pathway, and we're delighted to be joined by Rachel Foley from the Worcestershire Acute Hospitals Trust, who deployed our award-winning pre-op solution, Synopsis, back in February. Synopsis is the dedicated pre-op section of the Intouch with Health platform. Intouch with Health supports over 50 NHS trusts, managing over 30 million outpatient appointments each year, alongside an international presence in Australia, Canada, and Europe. Intouch is also part of the larger Vital Hub group. Throughout today's session, if you have any questions, please use the Q&A and chat features, but we will hold the questions until the end. We will endeavour to answer every question, but if we run out of time, we will contact you directly after the webinar with the answer. If you'd like to know more about Synopsis or this project at Worcestershire, please contact the team and we can provide you with a case study or any other materials. Alternatively, just leave a message in the chat Q&A feature and we can send you the materials. I'll now pass over to Tori, Head of Synopsis Projects at Intouch with Health.
Thanks, David. Hi, everyone. As Dave said, I'm Tori Dand, and welcome to our webinar about implementing a digital pre-op assessment pathway, again, with Rachel Foley. To set the scene, the agenda will be a brief introduction about pre-op and the Synopsis products, just so you're all aware of what the product is offering. Then we're going to jump into a conversation with Rachel, and at the end we'll have a Q&A, and as David said, if you want to just put your questions as we go through and we'll pick them up at the end. So to jump in, and just to highlight why pre-op is such an important part to a hospital, is because it really drives surgery, and surgery is where a lot of the revenue for a hospital comes in. So a good pre-op can provide a good surgery pathway. So Synopsis supports that in the sense that we provide digital solution for the pre-op assessments. We have the ability for patients to complete questionnaires from external sources, so they don't have to be in hospital. These are pulled into a clinical view, which we will see as Rachel talks us through, and the clinical team populate this area inside the hospital. The key areas for the Synopsis projects are always to save you time, to save you money, and actually to save your patients' lives through the risk assessments and the information we hopefully provide and bring out through the digital system. We operate across a number of NHS trusts and some private as well, and these are just a few of our customers. We have hit 120,000 pre-op assessment records this summer, which is great, and we are ever increasing and bringing on more patients through our systems, which is a fabulous thing. As I said, Synopsis has this two module set. So we have a Synopsis Home, which can be provided to the patient external to the hospital, and any time they want to enter it, complete it, before they go to work, during the lunchtime, on the tube, while commuting, they're able to complete their questionnaire. There's a flexibility there to the patient, which isn't time constraint to the hospital. And then inside the hospital, we have this product called Synopsis IQ, which is for the clinical people. It's tailored to the hospital's needs, the hospital's wants. We build that as the view that you want and the content inside it as well. And out of Synopsis IQ, we populate into other parts of your hospital, so whether that's an EPR or onto a ward. And our new development is actually into AIM solutions, so we can send the information from pre-op then into a live surgical area. So you're able to use that into your AIMS package for anaesthesia record. So with Synopsis as well, just the last slide I have on this product before we talk to Rach, is just the flexibility that having these different modules provides the hospital. So as an example, when the patient has been to see the outpatient's surgical consultation, they might say, please, could you just walk round to pre-op and complete a questionnaire using an iPad? or they'll say if there's a station or a kiosk that we want you to complete on, or they might send the patient away and they can go to home and they're able to complete it in their own time, like I said, and it's the same questionnaire but with flexibility for the hospital. That can then come back into hospital and it can be triaged by a nurse in real time. So if the patient is there doing it on the iPad, it can be done in real time straight away, or it can be done from the patient doing it from Synopsis home. Again, it's populated into the same view, and the nurse can triage without the patient having to be there, and it can be in a scheduled way. Also, the system allows the HCAs to be able to enter information into the same record, which means having all this flexibility and all this movement of information all into one record, you can build up a very robust pre-assessment product and case for your patient, individual and correct to your hospital's needs. So that's just my brief overview of Synopsis. And now we're going to jump into a conversation with Rachel Foley about how we implemented at Worcestershire, how that looked like, what benefits we found and outcomes, and then we'll open the floor to questions. So bear with me while I just stop my screen and I bring Rachel in. Hi, Rachel.
Hi, Tori, how are you?
I'm fine. Thank you for being here today.
You're welcome.
Cheers. So just to get everybody aware of who you are and your personality and how you run your pre-assessment at Worcester. So if you could just tell us a little bit about how you actually got into the pre-assessment role at Worcestershire pre-assessment.
Yeah, certainly. Well, I started off my career many moons ago in Bath, Royal United Hospital, where I worked in theatres as my first job and a recovery nurse. And then I moved to critical care. I spent a long time working in intensive care units. I then became a critical care outreach sister out on the wards, doing lots of health assessments. I then had a brief foray into working into IT as a business analyst, which sort of sparked my digital interest. And then the pre-op senior sisters post came up within Worcestershire Acute Trust, and I was successful, and I've ran the pre-op service for the last 4 years with a definite focus on implementing a better digital.
Fabulous, thank you, Rach. And if you could just tell the people on the call, the attendees, what does a pre-op in Worcestershire look like? So how many hospitals do you have? How many pre-ops you put in through a year? What does a pre-op at Worcestershire look like? Okay, so
Worcester's spread out. It's got three hospitals that we work at surgically, Redditch, Kidderminster and Worcester, but we actually outpatient on 7 sites within the area, so we have quite a large demographic that we have to cover. We pre-op on the three main sites. We do between 10 and 12,000 a year usually in a non-COVID year, and I have teams working on each site supporting patients. So we try and pre-op at the patients at the site nearest to where they live, so there's less travelling for them.
That's great. And your pre-ops right now, just to say, you're using Synopsis Home as well as Synopsis IQ, aren't you? So your patients are completing it externally at home.
Yeah, we're very focused using Synopsis at home. So the majority of our patients complete the questionnaire at home prior to either being triaged by the nurse for either a face-to-face, a telephone assessment, or a HCA appointment.
Brilliant. Thank you very much. So to go back in time, when we first met, there's a lot of elms. You already had a digital system at Worcestershire. You were already doing a digital pre-assessment. which was different compared to what other places we've been in and implemented at. It was a different approach for us. So what made you guys say, yes, we're doing it digitally, which is great, but we could do this better? So what made you come and find Synopsis?
I think the system we were using at the time was really clunky and it wasn't very intuitive. It didn't do risk assessments. We were duplicating data. There were some little glitches with it. A trained nurse was adding it. It would wipe the whole assessment. It didn't flow. It just didn't suit the needs of a developing service. We had a lot of patients who probably didn't need to answer all the questions, but all the questions were asked because it didn't hide questions that weren't needed, and it just didn't work, and it was very expensive to change. So we said, let's start again, look at what we want and what we want out of a system rather than modify what we were using.
Fabulous. And again, one of the main things, again, when we first met, you said to me, look, I want to reorder our pre-assessment. I want the nurses to see the patients first and then the HCA. So I want to recalibrate how our pre-assessment flow is done. So that to me was really interesting, and I was able to actually share with you another hospital and able to take you to another hospital who was doing that flow, and always did do that flow, and you were able to see it in working practice. And did it so has that change of approach actually worked out for you? Did it do what you wanted it to do? And are there any other flows that ideally you would like to change? All right, so I don't think we can hear you yet.
There we go. Sorry, I pressed the mute button. What happened was the HCAs were seeing the patients prior to seeing the trained nurse, and that either led to them being over-investigated or under-investigated, because we didn't have a true medical history in our old way to know whether they needed additional blood tests to what we would normally do. And we were quite keen to adhere to the NICE guidelines for pre-operative investigations. Certainly when I moved here, we were over-investigating over 60% of our patients, which is quite wasteful resource-wise and time. Some patients were sitting for 45 minutes waiting for. They don't need to do that now. And we've been able to modify our flow within the clinic. It's released time for the HCA so that they can take on phlebotomy and ECGs, whereas we used to, particularly at Worcester, send them to different departments, which prolongs the pre-op time for our patients. And obviously now with COVID, we couldn't do that anyway, so we would have had to change, but it was always on the roadmap to do anyway. Changing, I think I want to make it slicker. We've been really disrupted by COVID, and embedding the system in less than a month has been really difficult. Yeah. So I think we need to review our flows and our processes, and there definitely are some tweaks, but that will come with time. We've only been back working for the last sort of 2 months. In the process, I would say.
Yeah, just to point out, we went live 6th of Feb this year. So you got a good month, excellent figures, and then yeah, COVID hit. Yeah. But again, in May you went live with Synopsis Home, so it did show that even with
even though we were really struggling, we went ahead with Synopsis at Home. It was just perfect timing for us to go live with the system, and it solved a lot of our problems.
Fab. Again, going back to your previous system, so I know it's probably before your time, you went from a paper format to a digital system. Quite a lot of the people we meet when they first step down this road, they assume they're just going to move their paper documentation onto an electronic system, and they're not going to think about the risks. They're not going to think about what things need to be highlighted, or the other things within Synopsis that we've always built in, and I guess built as our USPs. So if you had a paper process, if you were going back to that again, do you think moving to Synopsis would have looked different if you were coming from a paper solution to Synopsis, or with a close from going from a digital system?
There was definitely, we still had some paper. Our telephone assessments were done on paper, and I think there was a bit of resistance because they felt they were having to put a lot more information in, but that's been lessened now with the at-home bit, and it's the usual old adage, it's quicker on paper, and certainly they did say that for the telephone assessments, but it releases time because it's all the information's in one area. We can copy forward a certain amount of data for those frequent flyers who've used it lots. That's a real benefit to our patients and our staff. And what I found is we found things that we could improve, and we've given them to you, and we said, how about, can we do this, can we do that? And slicker. So I think we had the same pain because my staff didn't particularly like moving from paper to digital, and then the same pain was for digital to digital. So I think wherever you are in the process, people like what they like and they get used to it, and we worked very hard on engaging the team so that they felt comfortable moving to a new system.
Yeah, nobody likes change, do they? But yeah, no. once we're in, we were good.
Yeah. So it was it was a lot smoother than I thought. I ever thought it would be. You know, I couldn't have asked for it to go better, really. You know, if I'd asked for a perfect rollout, it would have been what it was. You know.
That's all right. So going into the implementation process, we do two things. So we do a Gemba and we do a DCW. So just to bring everybody up to speed on what those two things are, and Rachel, because I said Gemba in the test one and she said, I don't know, explain that to me. So a Gemba is that we go, we look, we see. So it's a Japanese Lean Sigma phrase. And the point is that as a team, a Synopsis team, we come to you, we watched your processes, we watched your nurses, we watched your flow of your patients, we understood what information you were collecting, where it went, what it did. And that for us provides a huge amount of information, because then we know what you need from our product, so we can tailor our product even better, or show you in our product the things that would support you better. And it also means that we now understand you and can look after you a lot better. So that's really beneficial on our side. But were there things out of that Gemba that were good for you? What was important? Did you get any benefits out of this for you?
Yeah, I think definitely it showed where there's bottlenecks. It highlighted areas that we could make improvements, do things better for our patients. I think it's always good to have somebody else's eyes look over your service, because when you see it every day, all day, you don't necessarily see the gaps or things that can be improved. So you know, how I had very much a vision of how I wanted it to work, and my vision may not have been necessarily what worked, and so we were able to look at what we thought was good and bad of what we did, and modify it so that it worked better with Synopsis.
Yeah, I think your system was pretty slick as it was anyway, but yeah, I guess it was quite good for you, so I could go out across all the sites and say to you, they do it this way, they do it that way. If you take a bit of this, take a bit of that, we're going to move it into a lot more slick, like you said, slick way of doing it.
Well, it was great seeing other places, but you know, it certainly gave me a bit of confidence that I was doing the right thing. You know, I met some resistance, and it was like, and it was like, well, no, it works here, and this does this, and I think it gave me reassurance visiting other sites, definitely, and people who'd had it in for a while. it does make you look at things slightly differently.
Good. And then the other thing we do is a data collection workshop, so a DCW. And we had a big room in a very nice building. Actually, it wasn't the main hospital building, was it? And we collected as a group, pre-COVID obviously, and we went through all your documentation, all your folders, all the information you're collecting, and then we pulled it all apart and we rebuilt it in Synopsis, so we could customize it. And we're often told that Synopsis is too much. You've got too much information. There's so much for us there. Sometimes it can be a bit daunting. But how did you find that approach from us and the content we brought?
Yeah, I think we found it really useful, and I suppose it highlighted what some people may be asking and what some people weren't. I find it's always it's easier to take stuff away. They feel better when you take stuff away than adding things. So, oh, I've got that question to answer. Oh, I've got to ask this now, and I haven't got that because I'm actually removing stuff that we probably don't find useful. So, yes, they were a bit, oh my gosh, but once they get to know the system, understand where the questions are, understand it gets easier for them. And I think they needed to have patience to work through the system. I think that our difficulty was we went live in February. March 23rd we were redeployed. Pre-op was virtually shut down until July, August this year. You know, I still had nurses redeployed in September, so it's taken, some of my nurses have had longer away from Synopsis than they had with it. So I think that's impacted on, you know, how we use the system through no fault of anybody's. So I think it's a really good consolidation time now to look at the content again.
Another funny story is when we first started doing this, we'd gone through the build, we put that in place, and you wanted correctly to test the patient feedback volunteer group. So you asked your volunteer group for a patient, and I even remember the email saying, I need a patient to test an iPad question set in a waiting room by themselves. I think they were the 4 key words in that email. And through the door stumbled an elderly gentleman who was registered blind. He was partially blind, wasn't he?
Partially sighted, yeah, registered blind.
Sorry, registered blind. And yeah.
I think I had blind panic, thinking, oh my gosh, I'm never going to get anywhere with this. That was just...
Right.
Yeah, it did turn out all right. You know, he was au fait with an iPad, and he was able to actually teach me some stuff about the stuff that's available on an iPad for a patient with sight difficulties. He was able to read the questions with which I didn't even know about. You know, it was going to be a letter. You know, if you can't complete it, fill it in, or the nurse would do it with you, or there'd be someone sat with you. So it showed us the art of the possible, I suppose, is the way you can do it. The other thing that I want to bring up is when you remember when you were doing the timings at the Alex, and we gave somebody an iPad and they were sat in the waiting room, they went, oh God, I could have done this at home. And I was like, yes, we're implementing at home, it's going to work. You know, and that was a light bulb moment that the patients have said, I could have done this at home, I don't need to be sat here doing this. You know, so it just shows you that they are receptive and to it. So yeah, that was my heart did sink when he came through the door.
I think with the Alex group, when that elderly couple sat next to me, I went, oh, I wish we could have just done this at home, why do we have to come in? I think I phoned Michael, our sales guy, and just said, oh my word, she said this, can I go and record her? Can I ask her to go on video? But I didn't. But I was like, oh, this is gonna be on the banner across the trust website. Yeah. So you and I know that pre-op is way bigger than just pre-op. It goes further afield than just your pre-op department and just your staff. It goes into so many other areas. And you did something really special and different to educate other parts of the hospital, which I haven't seen them before. Obviously, information goes out, but you actually put out booths in corridors with posters, and we came along and supported those days for you as well. So I would really like you to share that experience with the attendees about what you did, how we supported you, what was good, would you do it again? The information's in there, and did you get anything out of it as well? Was it positive feedback or negative feedback?
Yeah, I think it's really important that we showcase what's going on in the trust. You know, the trust have invested in the system, and it impacts on medical secretaries, OTs, surgeons, theatre staff, there's ward nurses, and I think it was really important to share the news that we were going to be doing something differently, that they were going to access it in a it's going to be much more in depth than what we had before, and know how they can log in, and so that you came along and supported us. You gave away the odd free pen, which always goes down well with NHS staff.
Yeah.
And I think it was a really positive experience that we could showcase what we were doing and how we were making things better for our patients. Our trust motto is putting patients first, and that is what we've done with this system.
Fabulous. Would you do it again? Would you do more of them, or?
Oh yeah, definitely. I probably would have done more. I didn't allocate. I probably would have given more time and done it for longer. So I probably would have done a few days on each site, and I may have included a bit at maybe our bigger outpatient hospital sites, so maybe Malvern or Tenbury or Bromsgrove, where because I concentrated on the main hospitals, but the giving out of cards needed buy-in by the outpatient nurses. So and the other place that we rolled this out that wasn't in the plan was Eastham Hospital.
Yeah.
Wasn't it? So we've probably got 4 sites that we're using it in February. So
yeah, there seemed to be more pre-ops coming out of the woodwork once the fear was gone. We're like, where have you come from? Upstairs?
Yeah.
Okay. All good. So we've now implemented, and we did our patient tester. You're now live with patients. So what kind of feedback are you getting from your patients? So I know you've not had long really with patients doing it on the iPads, but have that gone quite positively? What feedback are you getting from them? And then Synopsis Home, what are you getting back from those patients as well?
Yeah, so we had we didn't have a huge we maybe get 1 or 2 a day out of 30 patients who were struggling to complete it, but I think that was that was easily solved, and we had people help them if needs be. I always remember some feedback I had from one of the trusts I went to visit. There was a 90-year-old man they didn't put him on the computer, and he was most upset about it because he said, I'm quite capable of doing it, thank you very much. And so they put him on. And another bit of personal feedback is my mother had surgery recently within the trust. She is a complete technophobe. She cannot even use a smartphone. She's got an old phone that she can just text on. And I got her set up on this iPad to do her synopsis at home. I got her logged in because I thought expecting I was going to have to complete it for her, and I didn't. She completed it all herself, which just, if my mom can do it, most people can do it, I have to say. So the feedback is good. We had some teething problems at the beginning, which is understandable, and we changed and we responded to that, patients putting their name the numbering wrong, NHS number, you know, but we were the first to go live with it at home. Nobody else had done it. So these problems were solved very quickly by yourselves, and it's not an issue. I think the biggest issue is getting patients to do it in a timely manner. But we're putting things in place to do that. Feedback's been good. We had some issues with emails, but that's been resolved now. So I think patients were frustrated when those problems occurred, but they were soon fixed. And I don't have any particular negative feedback since we fixed the issues.
Cool. You had a great project team. I was involved in it, but it was mostly Worcestershire. The team were great. Judith was an absolute angel from your projects as well, who led us through it very well. So who would you suggest to anybody going to embark on a transformation project for pre-op? Who would you say your key players are? You need some kind of buy-in or a group for a transformation of pre-op.
Yeah, I would say you need a clinical lead, so that you've got somebody to make the decisions about the clinical questions. I think you need a project manager. I certainly would have a business analyst, because I'd been a business analyst within the IT department. I did a lot of the mapping and the work that a BA would normally do, so that it would reduce the project costs. So either utilise people in your team who've got those skills already, or have a BA. I think it's invaluable to map out your processes. Even with my experience, there were processes that I didn't even know about going. And I think have you guys work really closely with you guys, because you're really helpful. And workshops with your team, so they feel included within the process. I definitely think that helped the buy-in, working with the team.
Definitely. So it's often referred to us that a digital, moving pre-op into digital, is an IT project, but we would always push back it's a transformation project. And then from all the conversations we've had before, I assume that's the same opinion you've got, but just to clarify, that is how you see this as well.
Oh gosh, definitely. So for example, we wanted to change the way we did things. Every patient got seen for an hour, irrespective of how fit and healthy they were, to how, you know, to what surgery. So somebody having a toenail removed who is 20 and fit and healthy would have an hour pre-op appointment. And some of the time they'd take an hour pre-upping the patient. So, you know, they'd find things to do. They'd do ECGs and blood tests that change their way of thinking. And I'm still working on that. You know, they still are, they don't trust the patient, and, you know, you've got to change their way of thinking. They need to trust in the product, trust the patient, and know where to pick up on cues. You know, they had their bit off pat when they were doing it before, and they've had to change that. So it's definitely changing behaviours and processes. So I would definitely say it's a transformation project, because you've got to give your nurses the skills and confidence in changing their ways, because they want to keep their patients safe, as we all do. Yeah. So it's really important that you support that.
Yes, definitely. Definitely. Patient safety has to be the centre of all this. Definitely. So going into the challenges that we faced, biggest challenge obviously is COVID. We didn't see it coming. So how have you been able to implement this during COVID? So yeah, where were the challenges? I guess your team being taken away, really.
Yeah, so the majority of my team, on March the 23rd or whatever it was like our urgent cases, you have a skeleton team, everybody else is going to ITU, including myself. So we, being an ex-ITU nurse, they wanted to work me. So I went, we'd implemented it, and we'd done it at, we'd got the Synopsis IQ in, and we're using that. We didn't have the at-home version, and to be honest, the at-home bought into COVID helped us buying into the at-home bit. There was an appetite for remote assessment of patients. There was that we were told you can't bring any patients into hospital. Nobody is to come into hospital. And so we had to work differently, and we had to work differently very quickly. And so it was really important that we pushed through the at-home bit, because that facilitated us working differently. I think it got better buy-in from the clinicians, both they also, we brought in interventional radiology, ENT and vascular, all of which we didn't pre-op prior to COVID, and now we are pre-upping, and we were able to go, this is the system that we've got. We bought this system, why aren't you utilising it? You want to assess patients, this is the perfect tool to do it. And that's how we did it. And so we're pre-upping stuff that we've never pre-upped before now.
Yeah. So you took a bad situation and somehow you extended the amount of work that you wanted to do for everybody.
Yeah, stupidly. I'm really proud of my team. They embraced it even through the most difficult time.
Yeah, you've done really well. You've done really, really well. I know we've talked before in this conversation that there were some pain points about moving to a new system with your staff. So have there been any positive impacts on helping the team embrace the new system, and are there things that we should have done better?
It's so difficult, because in an ideal world we wouldn't have had COVID, and we would have had time for the staff to get to know the system, to understand it. They don't fear the system, but they don't trust the patients. If they're not asking the patient the question face to face, ask them face to face. It's being able to show them and given them more time to get comfortable with that process. I very much wanted to reduce the times that we have telephone assessments. The majority of our patients are assessed over the telephone, and it's getting them not to ask every question again. I think within our trust and that fear and the break with COVID, I think they struggle. We were having to phone the majority of our patients anyway to just check on the CPE question, but in the latest release, CPE is dealt with, and I think that's really that's going to be a bit of a game changer for us. We're going to be able to triage a lot more to just support clinics, because we're asking that CPE question. I've uplifted my healthcare assistants, so they run their own support clinics. They don't have to necessarily see a trained nurse. Our telephone assessments can be completed in 20 minutes. Our face-to-face ones probably 40 minutes for a bowel surgery, but we have to give Clexane and do some education. So we've reduced the time our patients are in the hospital, which is only a positive in light of COVID.
And IT resource is always a challenge in a pre-op project. So what IT requirements did you say you needed in this project? Do you put in the project brief?
So we needed servers, we needed a test server, we needed iPads initially, but the iPads were until we got Synopsis at home, so we can hand those back. We needed some development work to pull the data through. I'm not techie at all, yeah. I enjoy IT and I enjoy the digital platforms, and I think it's a really good driver for change. But I don't understand all this stuff. I can just about work out what a HL7 message is. We pull through the data through the trust. We had a bit of teething problems through that, but we've worked through that. And then we've looked at how we can improve the access to the system through our patients. So we're text messaging, and we've got lots of things in place. Does that sort of cover what you mean?
Yes, yeah. Another thing though, to point out, I think your IT went exceptionally well, was that they've put your pre-op inside your website, so your patients actually just Google Worcestershire pre-op, yeah, and get straight to the questionnaire, which wasn't a huge amount of work for your IT team to add that link into your website, but I think has given a huge information back as well to your patients.
Yes, so our patients just Google Worcester Pre-Op questionnaire, and they click on a link, and then it takes them to our page, and I think that's really good. And it also feeds them our to our information, our electronic information. We've moved away. You used to give a big, we used to give a stack of paper to our patients. Many still came in the same pack when they were admitted on their TCI dates, and had never been opened or looked at. So we changed how, knowing we were bringing the system in, we changed how we gave information, because obviously it wouldn't be cost effective to post if they're not coming in for a support clinic, and we direct them to our website, which we improved. So so what I find very, I don't know where we were going to cover this, our breast cancer ladies often don't need to come in at all to the trust. They've been to our Haven unit, which is our breast unit. They've had their MRSA, they've had their bloods, they've had their MRSA swab. So once they've completed their synopsis and they're fit and healthy, that's one less appointment that they need to come into the hospital for. And breast ladies have a multitude of appointments to come for all sorts of things, and it really has benefited them for not having to come in for that appointment. And they're almost relieved that it's one less thing that they've got to do. And the Haven team are very good, because they make sure that they're in that position that they can do that.
That's really good. We've been doing synopsis implementations for a long time now, a really long time. We appreciate with our customers that it is a challenge for you guys to receive funding for this sign off of this project for pre-op. There is a clear importance of business cases, and you have to identify a return of investments, and then you have to jump through quite a number of hoops to get to the end. So if anybody's going to embark on a transformation project for pre-op, what advice would you give anybody, and is there any other support that we should have provided you with during that time?
No, I think you were invaluable. I think Michael clearly wanted to sell the product because he offered so much help, it was unreal. He helped us write our business case, and it was probably 6 times over that we wrote a business case. The business case was in place before I even took the role, so it's been on the agenda for a long time. I've been in post 4 years now, and this is my greatest achievement, is getting synopsis in 3 years after my role. People had tried and failed before me, so I think it was get you guys to help with the business case. You've got lots of evidence, you've got lots of numbers. Certainly my capacity is going to be increased. I've taken on extra specialities because of this system that I could never have done before. I've probably increased my capacity by 20% if I'm on the low side. I think there are things to improve, but I think climate of COVID, the fact that you've got something that your patient can fill in at home, and there's other systems out there, and we looked at lots, but they don't provide the whole record. It's not a pathway. We'll send you a PDF or we'll send you something. It's not a living document with the patient, and I think that's really important, that we've got an auditable living document so that changes, because things change between completion and them going to their theatre episode. So I think it's really important that it flows in that way.
It took you, well, Worcestershire 5 years to get the business case through?
I think so, yeah.
And to get funding allocated. So it's not a short
I
process,
say no.
it's not a quick fix. So coming on to the outcomes, it's our last section before we open to Q&A, so get your questions in. So I think this is where we're going to talk about the breast ladies, but what does a day in pre-assessment look like now? So how has it changed? What's the difference? What's the improvements there?
Okay, so we're still tweaking because obviously COVID, and we don't know how we're going to work. Certainly with COVID and the use of Synopsis, we used to work in silos on our 3 sites. We work much better as a team now. On a site who's the nurse in charge for the county-wide pre-op and is also doing the triaging of patients. The plan is they triage the patients and at the moment they phone for the CPE question. They then decide whether they're for a telephone assessment, they need to see an anaesthetist, or they need a face-to-face. In time they will specify whether it's 20 minutes, 40 minutes or a face-to-face. We pick up patients who are anemic or maybe have a high HbA1c before they even come to pre-op. So the plan is that everybody who's added to the waiting list will get a text asking them to complete a link, and if their pre-op's requested and they haven't done it, they will be followed up by my booking staff. We have business cards which we give to all our patients who, well, we should be, but in COVID not many people are coming face to face, so we give them a business card to say, here's a pre-op link, can you complete it. We also send out letters we were firefighting for the last 2.5 months and we couldn't put the processes in place, but we're starting to now. Our nurses see the patients quicker, we follow the NICE guidelines for investigations better, and we've got a fully auditable process and it's seamless. The anaesthetist used to write separate letters and on our document system, whereas they now write in the patient record, so the patient, it's there in one place.
All one episode. And obviously with the breast ladies, you're reducing the number of appointments hopefully they're coming in for. And
our ACLs would, you know, a young ACL would probably only come in for a 10-20 minute appointment with our healthcare assistant for obs swabs and picking up his information. He wouldn't need to see a nurse necessarily. So that's where we're working towards, and it's having the confidence to do that.
Yeah,
because they've got to see a nurse. Well,
yeah. So what was your favorite part of the project?
Working with you, Tori, obviously.
Yeah.
And the team. I think for me it was actually achieving it. I love seeing the progress and the difference it's made to patients. I think we would have really struggled with COVID if we hadn't had something like this in. It's purpose made for what we're doing, and we would I think it was a challenge, and I think it was great to see my team and me rise to the challenge.
Yeah, I think so. That was good. So what was your least favourite part of the project?
Oh, dealing with IT departments and the trust boards, trying to source things like iPads. I probably didn't plan that I really needed more iPads than I had. I probably didn't I think my timescales, I probably expected IT to go along with that way. But I really enjoyed the project. There isn't much I didn't like. there are things that I want that I haven't got yet, but
There's a wish list.
There's a wish list, and we're working through that. But I have to say, you guys have been so responsive to our needs. And I've worked with suppliers before, and I haven't been paid to say this, but you've been responsive to every issue or problem I've had. You haven't dodged my emails or my concerns. You've really embraced the project within Worcester to get us the best outcome for our patients, and I thank you for that, because you have made it so much easier.
Thanks, Rach.
You see, we've worked so closely together.
It's not nice to me. And it's recorded.
Yeah. We've won awards as well. You know, I've never won an award.
Yes, we have. We have. It has been really good project. So, but what's the most significant outcome, do you think, post development as well?
I think we are in a place to be safe for our patients during COVID. Our vulnerable patients have less time in an environment that they probably don't want to be in, or they're nervous about. We've got my nurses on another site who only saw minor procedures now seeing men.
Oh, that's good. And if you could go back in time, and I like this question, and put a sticky note on your computer one morning, so when you walked in to see it about the project, what would you tell yourself to do or watch out for?
Make sure my ICE link works. I want my ICE.
She wants her labs.
I want my labs. You know, I want my labs in it. Because and through no fault of you, partly our development team, we haven't got there yet, and that's probably the most frustrating part for me.
Yeah. Sticky noted, done. So thank you, Rachel. Thank you for your honesty, for being here today, spending
You're welcome.
an hour with us. We are going to open the floor to some Q&As.
There's too many.
Yeah, there's quite a few. So David or Colin, do you want to raise them up to us?
Of course. Thank you both. That was amazing. Thank you. First question is from Alison. Where and when would patients have their swabs and any physical observations done?
So some of the patients have them in outpatients, so particularly our breast ladies have them done in outpatients. We COVID swab at 3 days like everyone, and we do MRSA some in the COVID swab. We encourage they've had a blood pressure in the last year actually with their GP. We can use that. We say 6 months, so we would look on their summary care record or their e-referral to see what information was there, and if we didn't have that information, we would bring them in to visit a HCA clinic.
Thank you. This is from another Alison. Has this reduced the cancellation rate of patients on the day? On the day surgery.
I think in combination, yes. I think we were quite good, and we have a report that we review every month of our on the day cancellations. I think it identifies those who are anemic and have got high HbA1cs earlier than we would do normally. The other thing that I think we certainly, and one of my aims is we review the patients early, because they sit on a waiting list for 6 months or 8 months or however long, a year, and then they come to pre-op and we cancel them because their diabetes is out of control or their TSH is out of control, and we're picking up those things hopefully earlier, and so they don't come to pre-op after waiting for 6 to 9 months only to get cancelled and wait another 6 to 9 months because they're not fit to proceed. The idea is we pick those things up early and they don't get cancelled when they come to have their formal pre-op.
Yeah. Question from Sue. What's the feedback been from the patients?
Some like it. We have very little negative feedback. At the beginning, we had 1 or 2 issues with the registration process and emails getting blocked, but that's been resolved now. Patients are pleased not to have to come into hospital for so long. We used to have on the letter, this might take up to 3.5 hours, and it doesn't anymore. So I think on whole, the feedback's good.
Excellent. Question from Patrick. Does this link in with the shared outcome, with the shared decision-making process around informed consent to surgery?
No, we have, no, it doesn't. We don't use it in that context, I don't believe. What we are sent home with an e-consent prior to them being added to the waiting list. So that should have been done before they get the link to us.
Right, okay. This is a question from Richard. Can Synopsis integrate with other trust systems, including EPR, theatre, pathology results?
Yes, Tori will know more, but in my experience, it does.
Yes, definitely. And that, like Rachel says, that's where the value is. So she's desperate for us to link up to the ICE. So the labs feed comes in, we link up to EPR, we can link up to AIM solutions as well. But yeah, we have a number of ways of getting information in and out.
Thank you. A question from Simon. Do you still have a paper-based day of surgery record? If so, does this digital solution integrate?
We have, this is something we're working on with Tori. So I have asked Synopsis whether it can populate our day case paperwork. There's lots of risk assessments that we do, so Waterlow, MUST scores, VTE scoring, and it works out their risk assessment, and I want it to populate our day case paperwork and our admission paperwork. So that is our design and get that in place. It doesn't currently do it, but the hope is we'll be able to in the soon. That's our next bit. We were planning to do it, but COVID has sort of put a kibosh on stuff like that up until now.
Okay. I guess this one would be for you, Tori, from Richard. Have there been any supplementary at-home products added to help the patient do more at home for pre-op? For example, swabs and simple bloods?
Not at the moment. So we went live in May this year, and it's literally around the history question set, which we populate in. We've extended that to include the COVID question set as well. So Rachel's now warned if someone's tested positive or had some kind of interaction or has symptoms well ahead of seeing that patient. We do in the future want to make Synopsis Home able to take extra information such as leaflets, videos, and improve that pathway. So, but in a way that supports the hospital, so it doesn't take away from the hospital. We build to support the clinical teams.
Okay. And can Synopsis be linked up with other digital systems in place, such as blood results, ECGs, anaesthetic review?
Yes, all of those, yes.
So our anaesthetic review is documented on the Synopsis record for that patient.
Okay, thank you. It's from Alison. What about the patients who require anaesthetic review or more in-depth review?
So we would refer that to, we've got the process we use within Synopsis. There's a workflow place and notifications. So if we identify a patient who comes through and is triaged as needing review by the anaesthetist, we would send that to the anaesthetist straight away, and then our anaesthetists are allocated sessions, and in that session they would review their work list and they would see that patient. So it may be that patient has an echo or an anaesthetic review prior to being seen by the nurse, and that's all recorded on that one Synopsis record.
Thank you. There's another question from Alison. You mentioned how it has reduced the number of investigations. As patients are often over-investigated, has this been reflected cost-wise?
Oh, definitely, yeah. We have gone from 60. We were doing some work on it anyway. We went from 63% over-investigated, minimal under-investigation. My nurses do every test under the sun, or they did, and now we've reduced it to only 23% of our patients are over-investigated, according to the anaesthetic audit. And we hope to do a piece of work once we've got Synopsis properly embedded following COVID to see if we've reduced it further. I missed some of your questions, so did that cover it, David?
Yes, it did. Yeah, thank you. So from Susan, what's the timings of the home review to ensure this information can be triaged in time to get a face-to-face in before the pre-op date?
So we're still working on the flow, because we've been firefighting. At point of adding to the waiting list, they would normally complete their questionnaire, and it worse. We did have a bit of a backup for a couple of days when we were having problems with emails coming through, but we triage daily so that there's very little waiting time.
Thank you. How did you get the patient information to patient with this system?
So if they're coming in for a healthcare appointment with obs, swabs, and so on and so forth, they will be given the patient information then. If they are triaged as not needing to come in, they are posted our coming into information leaflet, which is a 4-page A4 leaflet, and it gives us links to the nurse ticks which electronic information they want us to read prior to their surgery, and we highlight those and then post them on. There's a number where they can phone us if they want the paper copy, and then we would post the paper copy out. But on our we've got quite a comprehensive website that they're directed to. If they are struggling, so we would post the paper out if they wanted us to, or they say they can't access the internet, then we will give them paper copies. So we try and cover it. The procedure consultation is given by the e-consent by the consultant. So that's done when they're listed.
Okay. This is from another Alison. Has it helped you with urgent day cases? If so, how?
Yes, because they can be listed and they can complete the questionnaire that night. So, for example, we had 2 day cases sent through yesterday. They were phoned up, they completed their questionnaire, they've been triaged and they're being seen today. It means that we can slot that they don't need as much time, so we can slot them into our workday better, and we can probably overbook clinics a bit easier because we've got so much information about the patient before they come.
Okay. From another Alison, you've mentioned about picking them up early, but how far ahead of surgery do you start the process?
We start the process, well, the hope is we start the process when they're listed. The panel, they will get added to the waiting list. Our pre-op wait is 6 months. So what we do is we triage it and bring in anybody who needs bringing in, or recommend what sort of pre-op. And then the process is the pre-ops are requested by the secretary when they're due to TCI, and then that will get reviewed by the nurse in charge, and she will decide whether that's still valid or whether they need a phone call, depending on the timing of when they completed it and to when their TCI date is.
Okay.
So we're following our normal process, but we've just got that bit more information before they come.
Okay. And does or how does this affect the role of the booking team with appointments?
So I think my booking team would say I've created more work for them, but they're working more sensibly, I would say, because we hadn't got all our processes in place prior to May when we went at home. Had to rush it because of COVID, so we've had to work on the hoof a bit really now, but we're starting to put things in place like the text messaging of the link. We're getting better buy-in from the surgeons to give out the business cards for the patients to complete, and so there's less chasing to do because everything was so short notice. We've had to respond to that, but now we're getting more notice about surgery. We can put the original plan in place, and it will be less impact on my booking coordinators.
Okay, thank you. This is from Evelyn. What safeguarding risks are undertaken?
I'm not quite sure what.
So with regard to direct question for DA.
There are safeguarding questions within the questionnaire that we go through with the patients, if it's indicated. I'm not quite sure whether that's what you were asking. I'm sorry, I don't quite understand.
Okay. Can the reviews be done remotely? From Alexander.
Yes. We have and Synopsis can be accessed through our Wingu platform.
Yeah, as long as they've got access into the hospital's servers, that's fine, because it sits within the hospital servers.
Okay, and from Paul, does Synopsis integrate with your Cpet system?
No.
That's the end of the questions.
Thank
you very much. We've overrun by a couple of minutes, but thank you very much for staying around to answer all the questions. If there's any other questions that anyone would like to ask, then please drop them into the Q&A or the chat feature, and we will respond directly to you after this event. Otherwise, thank you very much, Tori. Thank you so much, Rachel.
Thank you.
You're welcome.
We hope everyone's
Thank
got a
you.
lot out of this.
Great.
Thank you very much.
David, there's a number of people, sorry, it's Colin, there's a number of people just asking how we'd access the recording, so we're sending information out after that. And I think there are a couple of other interesting things that came up about informed consent. There's a lot of interesting things that came up, but about informed consent, remote bloods and obs. Just as a point on that, as Intouch with Health, we're working with a number of an ecosystem of a number of suppliers, and always looking at developing this side of it, and even more so and we are on with that, and even more so now as part of Vital Hub. Thank you.
Okay, thank you everyone.